like is a little clearer, maybe. Like this. Is that a little clearer? Yes?
Kind of. It's so tiny, just so small.
Well,
Very
you don't want to
small.
see the other one because on the computer, it looks like this.
Oh, yeah, no.
The other one's a little bit more legible, isn't it? So here's why I said that. I figured it might be a little bit easier. No?
It's not clear.
Why is it not clear?
I don't know, it's kind of blurry.
Why is it a little blurry?
Maybe it's the background?
Hold on.
It's
It doesn't have that clarity. Yeah, it's just cloudier.
There you go. Different background.
He's so done with this one. Good. Perfect.
At least we've tried.
It is in your book.
Oh, yes.
Yeah, but you can rest assured that we're at least trying.
I know. I'm just.
I needed the visuals.
I'm trying to stay
Now,
invested.
notice this, it's breaking it down where it's coming from. You guys recognize what these are all located? Yes or no? No?
Generally, yes, generally speaking, yeah.
So you'll see top left is the proximal convoluted tubule. The top, or the renal corpuscle, which is basically the glomerulus, is the top right. Right below is the distal convoluted tubule. Right below that is the collecting duct.
Do you
On
see?
the lower left is the loop of Henle, and these are all reabsorptions, and where you have the tubular secretions at the bottom. So when you're looking at it, like I said yesterday, renal corpuscle or the glomerulus is where we actually see most of the filtration. That's our first occurrence. And then the tubular events, reabsorption, and filtration, you also see occurring at each one of these. Like I said, they are kind of where we actually see a lot of it being repeated. The reason why they're repeated is mainly because it's just a little bit here. Maybe the percentages are higher in one portion than another for the reabsorption of that component and lower in a different portion of the tubes. Okay? So this is just an illustration. But overall, water is reabsorbed 65% in the proximal convoluted tubule, 15% in the loop of Henle, about 10 to 15% in the distal convoluted tubule, and about 5 to 10% in the collecting duct due to anti-diuretic hormone.
How much did you say was in the distal?
10 to 15%
Was in the distal?
distal.
And then what was the, and it was 5 to 10?
5 to 10 because of anti-diuretic hormone affecting the collecting duct. And remember, it's at the beginning of the collecting duct. It's not really that far down in the collecting duct. And remember, filtrate is just filtrate. It is nothing more. It is not really urine at that point. Okay?
I'm sorry, at what point you say that it eventually would become urine?
When it cannot actually have
When it
any
can't
changes.
change, it can't change, okay.
Yeah.
Right.
And most of the time, we think of the collecting duct as a location where it can't change, but there is a certain level that it can still change there. And remember, if you're actually looking at it in most circumstances, you're doing all the other absorption and reabsorption at tubes. But generally speaking, if you are in a situation at that moment in time where you are losing moisture suddenly from something else, whether it's exercise or the temperature change, then you're actually sweating more because of the humidity and the heat. Or let's say something that's more traumatic. Like you just cut off your arm and you're bleeding out like a sieve, like Niagara. Yeah, like I said, might as well give it a real dramatic, really
Flare.
visual. You don't want that dramatic? Okay, so not that dramatic, okay.
I don't mind that dramatic.
So we could actually see what happened down in Texas recently, unfortunately. Where bleeding out occurred suddenly, uncontrollably. I'm not trying to, reduce the trauma, but I'm trying to let you guys know that when we're looking at such a severe amount of water loss, it's then going to have a direct effect on what the body does to try to compensate. When we look at people that are, and I talked about this maybe yesterday, maybe a couple days ago, when we actually see people that have severe burns and they're losing moisture through their skin because it's actually evaporating so fast that the body cannot actually control it. That will have a direct effect on the kidneys also. To reabsorb more of that moisture, but at some point, it's going to cause dehydration, and what's going to happen is the kidneys will fail due to that. Okay? So that's why a lot of times you have to look at what else is going on. What is the cause of aging? Why it's doing whatever it's going on at that moment in time. Okay? So this is just an overall chart. It gives you an idea of what's going on. You'll notice water, 65% there, 15% here, 10 to 15% here, 5 to 10 to 9% there, okay? You'll notice that when we're looking at the proximal convolution, like we talked about, glucose is there. I would say also medications are actually usually filtered at the proximal mostly. And when I say medications, I mean you take antibiotics, you have to break it down to a safe level, and it gets pulled out there, tubular, okay? What's that? In the proximal, okay? And then you get readjustments along the way. You get readjustments because something goes into the tissue space before it gets into the capillaries, and so what happens, it changes the concentration in that tissue space around the nephron. So it can actually then move back in through reabsorption and then move back out because of the changes that have occurred on those concentrations. That's why I also mentioned that when we looked at the loop of Penley as it's going down, you'll notice the coloration changes here and here. They are darker colored here and here because it's getting more concentrated, less water.
Which means there's more sodium.
There's more sodium there, yes. Let's get another visual on this so you guys can see this also, which looks like this one. This one is actually getting you to actually understand the volume. Okay? So what are we looking at? We're looking at the nephron, lovely nephron. Isn't that a wonderful nephron? Okay, so what do we actually see as the 300 as opposed to 350 or 550 or whatever the numbers are, or 900 at the loop where it has the hairpin turn of the loop of Henle? You're looking at the concentration of the solute, the amount of the particles, basically. And then what we have is as the loop is going up, the ascending loop of the loop of Henle, you're actually getting more of the particles moving out, and therefore the summit is pulling water out. Reabsorption. That's why you're actually seeing the levels are higher here in the tissue space than in the tube. So what happens is it migrates out. Sodium moves, water moves. Concentration difference, sodium moves, water moves. You guys follow that? Over here, it's the same, so it doesn't move. Here, it's the same. Here, it's the same. So eventually you get it where you see the particles actually getting, where you actually have the urine not quite as concentrated. Eventually. It
So the
gets diluted.
sodium goes out, the water goes in,
Yep.
so the sodium level just drops all the way.
Yeah, so what happens is though, the water actually follows the sodium. It follows the sodium, but what happens on the ascending loop, the two cells, remember what we talked about with the histology of it? The cells become a little thicker. So what happens is it prevents some of the particles that move across that membrane into the tissue space. But we have smaller molecules or smaller particles, they can still move, like water is typically one of them that can move. So how much urine do you get? 65 out of the 300. Particles in the urine. You guys like that one? Yes, no, maybe? Let's take a look at also what happens in another way. Let's get this one over. Ooh, look at that one. That one looks really nice, doesn't it? Ooh, wow, we're getting pictures of it. It's like a model. Right? Did it wink at you? Did it wave? No. Okay. So this is actually looking at a little bit more details as far as the sodium and the water. That's all it is. Okay? So you're actually looking at a little bit more details to try to get the same idea. Remember, the previous one actually gave you more of a generalized picture. This is getting more specific as far as those details. That's all it is. Okay? Make sense? Okay. And it also gives you some of the concepts as what's going on with the osmosis, the diffusion, and you also have facilitated transport actually occurring too.
How
And
come the concentration of the urine is greater in this graphic when it's still, did it start with a greater concentration?
well, in this one, we actually started also at 300.
Okay, so then
Okay.
how it's more concentrated?
So now it is still going, and they came down to 1200, okay, at the loop. This may be a juxtamedullary as opposed to the other one, which may have been a conical, where it didn't go quite as deep to the medulla. That's why. So they're trying to give you, which was actually about 750, 800, if I'm not mistaken, from what I recall.
750.
900.
Let's make my favorite.
I literally saw 7 something on the bottom.
Yeah, it was towards the bottom.
Yeah, towards the
I thought so too.
Yeah, it's
900.
900 at the
Oh, I guess I was looking at
Yes,
that.
that's why I thought.
What's that 65?
65.
Concentrated urine is 1200 in this
Yeah.
way.
Whatever.
So what occurred to make that a concentrated urine?
What made it concentrated?
Yeah,
You dehydrated.
so this is like a dehydrated.
Yes.
medulla.
Yes.
Okay.
Okay, so does that make sense? Okay, good. Let me just put this image up that may actually give you a better insight of what's going on typically. You'll notice that you have the blue and you have the red. Do you guys see that? This is indicating the water, and it's also indicating the sodium as it's moving. You'll notice the arrows that are larger is where you're having more movement. The smaller arrows are where there's less movement. see that? Yes? So what we see is that at the top of the descending loop, you have more moving across. And as you're getting further down towards the bottom of the loop, or where I'm going to call the hairpin turn, you have less because the concentration differences in the tissue as opposed to inside the loop of Henle is not quite as different. It comes very close to almost the same, 750, 750, inside and outside. As opposed to the ascending loop where it starts going up and there is still a greater difference. So they're actually having more movement there, okay? Clinically, one of the big things is diuretics. Let's talk about diuretics. You guys know what diuretics are? What's that? Yeah, water pills. Big item. Why do people take water pills, by the way?
Because they have water retention.
Water retention, yeah. Typically what happens is, and I want you guys to realize, if you actually have somebody that has a high sodium that they've actually consumed over the course of their life, what happens? The sodium actually not just is in the blood, but it actually goes into the tissue spaces. And when you have it in the tissue spaces, what did I say that happens with water?
Or they can break down the cell, burst.
It causes the burst. But what do we also see happening? The sodium in the tissue draws water out of the capillaries, the blood, and it actually retains water.
Is that when you get edema in your muscle?
You can get edema, yes. Okay? Over a course of a lifetime, having this similar diet, I want you to realize a lot of people don't change their diet, they don't change things very often. It's hard for change. I want you to realize that. So if you're on a high sodium diet, relatively speaking, what's going to happen over the course of, let's say, your lifetime? Chances are you're going to have more sodium than you normally would have. And so what happens is you have more of a retention of water. High blood pressure is the number one thing that you may notice as a symptom of what's going on. But actually, you may actually see swelling in especially the lower limbs, where you actually have that edema.
Could you get like pain from that too?
Sure. Keep in mind, you can have a lot of things happening. It may be difficult to move because your legs are heavy with water. One of the things that happens, keep in mind, there's a variety of things that could happen. So what happens is, a lot of times people will take diuretics to try to correct that, or get prescribed diuretics to help, get rid of it. And a lot of times the diuretics may actually cause more potassium going into that tissue space and therefore exchanging it with the sodium, so you can actually get it moving back into the blood supply and then going to the kidneys. Neat stuff, right? Very interesting. But it takes time. Sodium usually leaks out in general. Potassium leaks out. Sodium usually takes more of an effort. It may take ATP to actually get it to work properly. So when we're looking at it, it's a long task, all right? Because if you've developed this over the lifetime, it's going to take a long time to correct, if it can get corrected. But as far as how it affects the kidneys, though, and that's where we're looking at right now, what we see, it inhibits the cells within the loop of Henle that actually are involved in movement of the water or the sodium. So that actually affects urine output. When we look at it, some of the things that happen with this, you have different types of substances that can also affect this. For instance, caffeine is a diuretic. Where do you get caffeine? We know that, don't we?
Yep.
Coffee. Where else?
Soda.
Soda. Tea. Where else? One that I know sometimes one of my daughters keeps asking for. Chocolate.
Oh, chocolate.
Mm. Sweet treat, right? She's always asking, oh, you gotta go to the store? Can you pick me up some chocolate?
Is that found naturally in cacao?
What's that?
Is that found naturally in cacao?
Yeah, it is.
Cool.
Should just get her the healthy dark chocolate.
Yeah, I know.
That 85% dark chocolate.
Yeah, I know.
People can't even stand to eat it basically.
Yeah, she doesn't bother with it, so you know. Yeah, I like that.
Just say, I'll get you chocolate, it has to be that way.
Yeah. So what happens with caffeine, it does inhibit sodium reabsorption. So therefore, it causes an effect on the water. Okay? Alcohol inhibits your antidiuretic hormone. Anybody drink alcohol? Okay, all right.
Not really.
And I want you to realize, think about it this way, how many times have you actually socially went someplace and drank, let's say, something, I'll just say it that way, or 15. Yeah, I know. I've heard people do all kinds of stuff, depends on their size.
15 bars? Like bar hopping or 15 drinks? Or what were you saying, 15?
15.
Just
You 15. You interpret it.
Okay.
Okay,
The size
I
whatever you-
remember when I was younger and I was actually an undergraduate, a friend of mine and me, we'd actually study organic chemistry. And you know what we used to do? We used to go bar hopping in New York while we were studying. And we'd go to all different bars. There was a bar downtown that was called the Raccoon Lodge with a honeymooners theme. Okay? All different pictures and all that, you know, the program and all that. We used to go to another bar where we knew the bartender. I'd buy a pitch of Heineken. He gave us a pitch. My friend would buy a pitcher. The bartender would give us another pitcher. So we went through, 4 pitchers at least per night. 4 pitchers of beer.
Oh my God,
Heineken.
full?
Yeah.
I don't think I would even.
And then I drive home.
Hey.
Well, when we were bar hopping in New York, I used to drive there and drive back.
Where's the police at?
Oh,
Where's the
you wanna know
police
another
at?
story? A different friend of mine, we went up to this place we used to go to, it's no longer. It's actually it used to be well known because it was in a movie. It was actually named in a Billy Joel song. And a lot of people from the theater district would go there. And other famous people. And actually, when we were there, we saw them with the blueprints and plans for the new Yankee Stadium before it was built.
Nice.
Okay? Anyway, we left there. I don't know how we got home. We got stopped and the cop just said, let us go. I drove there. I could not drive back. I was that bad.
Oh god.
Yeah, some coffee just.
The coffee man.
Oh, gee, paperwork. Oh, it's not worth it. Yeah, you didn't kill anybody? Oh, good.
But they
Keep
do
moving.
sometimes, they're kind of iffy about it, they would follow you.
Yeah, well,
I've been there.
so I've had my experiences.
Yeah, I'll do that.
I've had my
Kind of
experiences.
terrifying.
But the bottom line is, what happens when you drink a lot? Typically.
You throw up, you have to go to the bathroom.
You have to go to the bathroom.
Poisoning.
Because you inhibit the anti-diuretic hormone, so you actually urinate more frequently.
That's true.
Or you
Especially with beer though, I feel like.
Oh,
Yeah.
yes.
Yeah.
Yeah.
Like,
Yeah, go on, 10 minutes later.
like you would literally
With
have
beer.
to be in the
Why
bathroom.
is it like when you urinate
Oh, yeah, me
the
too.
first time after you drank a lot, you feel even more drunk?
I have no idea. That never happened to me.
First time, wait, what?
The first time you urinate after you've been drinking, you feel more drunk. I've never had that
Yeah, it's
experience.
like, we call it break the seal.
Break the seal.
Also, yeah, that was the question yesterday.
It's the
Like,
first
why,
yeah.
like, why does that happen? Like, why, if you go to the bathroom once, that's the end. Like, you have to,
Yeah, no, then it's
like,
actually
go.
break the seal.
Yeah, you keep going and going and going.
Yeah, well,
Why is that?
that's because you already have the anti-diuretic hormone that's actually causing you to go. Go, because alcohol affects it. Affects the production of anti-diuretic hormone.
Okay, no, that's not.
But you don't have to go like that badly, like
No.
until that first time you
Yeah,
go.
that's a
Like,
Okay, you go. I remember, so, you know, different things happen,
Yeah.
so. Yeah, you don't know how bad it is.
I mean, yeah.
The way he puts it though,
I mean,
you
it's-
don't know how
Yeah.
bad it is. He doesn't even know how much I drink. He's like, you don't even know how
I
alcohol.
mean, it's
How
4
many
pitches
people
a
were,
day
how
sounds
many
like
people
a
were
lot.
splitting the 4 pitchers? Like, how many people were splitting it?
Just
Two? Okay, so you each had 2 pitchers, essentially.
Wow, you
Yeah.
felt really gassy.
And that's after we came from someplace else.
You gotta,
Maybe like
your tolerance for a lot of things is just really high.
That's when I was young.
I'd-
Younger.
I'd be scared if you were not right now.
Yeah, I mean, I remember going to my fraternity house and I finished
Oh,
off
you
a
were
half a
a
bottle
frat. It's making
of
sense
ice
now.
cold vodka,
Oh, ice cold vodka? Half a bottle?
straight up.
Which frat were you in?
Huh? No chaser.
Who chases vodka? Come on, do
So
it
here's my
right.
question, which frat were you in?
Don't worry about that.
No, I need to know.
Don't worry about that.
Which one was it?
Don't worry about it. So I've had all kinds of experiences. That's all I'll say. That I can share at times. Okay? Prescription medications like like we just saw, that's also diuretics. A lot of people take diuretics. Why? Depression, diet. You know, those anorexics will take it so they don't eat.
And they get rid of whatever it is then.
What's that?
Is that a good thing to don't eat? Especially when you're on a diet?
Do you think so?
Yeah, but no, well,
Starvation diet does not work.
No.
We already established the fasting is a
I
word.
mean, honestly, I don't know, at some point, yeah. Because you can't stop eating. Why is everybody looking at me like?
You can stop to some extent, like I said. You can stop to some extent.
What about those
but
diet
it's
pills they
all
had
a
with
matter
meth?
of amounts, okay? Moderation. You go too severe, and what happens?
You miss
You
it.
mess it up. That's basically what happens.
What suppresses the appetite like that? Just curiosity, just start.
Different things. Did you guys ever notice? And I'll just say it this way: stress can do that, but I will tell you, if you actually look at some of the dietary pills that they used to have out on the market, a lot of times they contained a lot of caffeine
yeah.
to suppress the appetite.
What was that ingredient they took? It was a big one. They took it off the market.
Methamphetamine with diet pills?
What was it? They said again?
Are you talking about
Oh,
the diet pills with the methamphetamines on it?
Yeah, but I think no.
Yeah, they used to make diet pills
Yeah,
with
we wrote that they had to
methamphetamine.
pull it off the market. People were dying on it.
Yeah,
Yeah,
that's
because
probably that.
only the fat was coming out, right? I think.
I don't know what was.
They were
going on.
doing meth.
They were dropping
Yeah,
that,
that's
yeah.
all it
And
was.
then, like,
It
I mean-
was
they
something
were having too much diarrhea.
So, I mean, in all reality, what are you looking at? You're actually looking at something that's actually increasing the nervous system to actually reduce the ability to feel relaxed.
Take care of one problem, you get another.
So what happens is you don't feel like eating as much.
Oh, is that why if they drink coffee, like you don't feel like?
Yeah.
Even though you should eat something in the coffee.
Yeah.
This is the thing, I don't drink
But then
coffee.
it doesn't
Like,
feel
I
like
don't
you
drink
should.
coffee.
Yeah.
I don't drink coffee.
I didn't start drinking until I got to this class.
Happens.
I can't drink coffee.
You can't drink water?
Oh, I
Yeah.
can't.
Yeah, I can't.
Sometimes I shake. Oh my god, yes.
Really?
I shake.
I have a heart condition, so
Oh, that's why.
it increases my
Yes,
palpitation.
that makes sense.
It affects me a little too much.
Yeah, I
I
know.
had an affair, found out once that I was gonna die of a heart attack.
Yeah, well, I'll say it this way. As you guys didn't notice, I drink coffee all day, all night.
I know, I go crazy. I feel high, yeah, it's weird.
Cannot say the same, we have two different ways.
Well,
You're still
metabolism.
healthy, yeah, you're still healthy, so it's
Yeah,
okay.
so that's fine. So, do you guys follow that though?
With
Good.
all the stories.
Oh, that reminds me, I got a story that I did want to tell you guys about, and I'll tell you in a moment. But let's get through this one. When we actually are looking at kidney function, of course, what do? We do the urinalysis. We talked about this earlier today, okay? We look at the different values, physical, chemical, and microscopic, right? We talked about that. We also do screenings, like BUN, which is basically looking at the nitrogen, the urea, and the blood, okay? We measure the creatine. We try to actually also analyze it to see what's going on. Because basically creatine phosphate is one of those substances where we actually are moving the phosphate, the inorganic phosphate, along, even when we're looking at ATP. So it actually is involved with the muscles, okay? But we also look at renal clearance. Now, what is renal clearance basically? We're looking at how long it takes to pass substances through the kidneys, okay? Specifically, let's say insulin, all right? So basically, we have to track the patient. There's different ways of doing, there's different approaches to it, so I want you to realize. And a lot of things, what we do is we look at how, when we have problems with the kidney, we look at dialysis. We talked about dialysis already. Okay. So, hemodialysis and peritoneal dialysis. We talked about both, right?
Yeah.
Yes.
What was the other blood screening test? It was the renal plasma clearance. What was the other one?
Bun.
BUN. B-U-N. Okay. Blood, urea, nitrogen. Okay? And remember, nitrogen is actually part of the components of DNA, ATP, amino acids. So when we're breaking down amino acids or proteins that are the larger structure, that's what we're really looking at and how that's actually doing. And keep in mind, when we usually look at liver function, part of the liver function is to break down the blood into its parts, where we actually break down the proteins and we break it to heme group, and that's how we're actually deriving the different bile salts, which becomes bilirubin, biliverdin, urobilinogen, which is what we tested for in the lab. Okay. We talked about the structures. When we actually get the urine formed in the renal pelvis, we'll say, it transports down through the ureters. We talked about this. The ureters actually are going to, and you have calyxes, major calyx, minor calyxes to going to major calyxes before it gets to the renal pelvis. We talked about that, and it goes down to the urinary bladder. Well, we actually have peristalsis in the ureters, and by the way, when we actually look at it, a lot of times when we look at the ureters, this is, something that we already talked about, but I'll mention it again. Like I said, they're not part of the abdominal cavity, they're behind it. So that means they're retroperitoneal. They do actually undergo peristalsis, just like our intestinal tract. Okay, so you have movement of the particles down. You also have a certain amount of gravitational pull. Here's an interesting thing though. Individuals that are thinner typically have more possibility of abnormalities with these, meaning they get twisted or they actually have an irregularity to the structure. And that's when we would actually do a radiographic type of test that's known as a, what's it called? IVP, where they actually tested by actually using radioactive isotopes in an IV. We have the bladder emptied, or actually, yeah.
What do you mean by emptied?
Emptied?
Yeah, just like
Voided.
just completely, just no-
Completely void.
like, do they have to like do an insertion to
Nope.
draw any remnants,
Nope.
or just
Nope.
natural void? Okay.
You do the peeing, not into a cup,
No.
into the toilet.
Yeah. Got it.
You get the IV, you take pictures periodically along the time, see how the structures are identified with the radiographic or radio, with basically with the radioactive isotope in the urine that's forms, to actually see whether the structures are normal or abnormal,
Interesting.
anatomically.
Okay.
If they're not anatomically correct, they may have to have surgery to correct. So that's one of the things. If we actually look at the ureters and there's a problem like kidney stones, a lot of times it's a problem where they get stuck. So sometimes they'll actually have to use some sort of endoscopic type technique to actually get them broken up or dislodged. One of the techniques is they actually go in and like clamps to actually break it up manually. Sometimes they use sound waves. Sometimes, so there's different. Sometimes they use a laser type technique. It varies as far as
Laser inside.
yeah, laser inside. Laser shoot with a laser.
Boy.
So nice, neat stuff. But typically, they don't like to go in if they don't have to. It's easier, and it's also better to let it pass naturally. Okay? Because basically, if it can pass, you're not going to have intervention
That's for a stone.
for a stone. Yeah. Because remember, if you go in, it's an invasive procedure, which then may cause a possibility of infection. So that's why they don't like to do that if they don't have to. Okay? And of course, one of the things that we'll see is the ureter is about 10 to 12 inches long. So when we're looking at the ureters, then, and of course it varies based upon the size of the individual. Let me see. How tall are you, Chris?
About 5'8".
Okay, you're not that tall.
Not really. I was short.
Sorry.
Thank you.
No, I'm just, relatively speaking, that's why I asked,
Oh, okay.
okay? Anybody know Andre the Giant?
Hell yeah.
What do you think of him?
I think it's amazing.
He passed
Well, how many
He
beers?
passed away, yes, he
He
did.
passed away. Come on, Princess Bride, his WrestleMania.
Okay, chances are his ureters
Did you
were
see him hold
bigger,
the beer?
longer. Okay,
I'm sorry, his what?
Is you?
His urine? Yeah.
his ureters were longer relative to his body size. Okay, that's my point. Whereas you get somebody that's short, like for instance, those nice, lovely people that were in, where is it?
Wizard of Oz?
Wizard of Oz.
Yeah, Munchkin.
They're shorter ureters, okay? Relative to their body size overall, okay? But otherwise, excuse me, everything is the same, basically. Okay, they lead down to the bladder. We talked about this. The bladder is typically muscular,
Yeah.
And when we look at the bladder, or shall I say the ureters, they will actually have 3 layers of muscle, or 3 layers, basically, okay? The bladder itself is muscular. Locationally, it's relatively hollow. You'll actually notice the tissues, the epithelial tissue, you may remember this, was made up of transitional epithelium. Okay, so what we actually see is, because it moves so much, you have squamous, you have cuboidal, and you have columnar cells that are stratified. So we actually have that. They actually are, when the bladder, it's posterior to the pubic symphysis. You guys might notice when you're full, bladder-wise, it extends, it creates pressure. That pressure on the walls are what you feel. And typically what happens is you actually have developed a means of identifying it. And it tells you, sends a message to your brain that you should go to the bathroom at that time to release it because it's full. Now, if it's full and you can't, what happens? You override that system. You actually tell your body, I can't go now.
What happens in that process though? Like, how does it get constricted like that?
Basically what happens is you're saying you can't release it. If you don't, what happens is this, you would actually wet yourself. Anybody remember when they were a baby? You do, Chris?
No.
Okay, you shook your head yes, that's why I asked. Typically what happens is the infants don't have that control because they didn't develop it. And so what happens is they don't have the mechanism to think about it and recognize when they have to go and when they don't, typically.
I have a question.
Yes.
They say that boys wet the bed more than girls do when they're kids. Why is that? I guess. Just like
This is so we're trained.
What's the?
It's probably the bladder. Because boys, in general, have less structures in the pelvic cavity, which can actually press on it. So girls, they feel that pressure much more often, and so what happens is they recognize that they have to go more frequently.
So boys just get
Boys,
restless.
yeah. Boys, they get active in something else, and what happens? They ignore it, and they do whatever they're doing because they want to ignore it. But here's the thing, like I said, a lot of times when you actually ignore it and you actually do it throughout your life for a long time, it then causes the incontinence where you can't control. Infection can cause incontinence. Damage can cause incontinence. There are conditions. I knew somebody, let me see, let me think. Yeah, I knew somebody, they had problems structurally with their urinary system where they wore diapers throughout their life.
Like it was just a
Yes,
malformation?
yes. And they were incontinent constantly. So this is, it happens. But basically what happens is you usually get the bladder, let me just do this so you guys can see it this way. You got the bladder, and basically what happens is you have the sphincter muscles that actually control. There's internal and external sphincter muscles. They actually are involuntary muscles, but you can override them. And if they relax, you release the bladder. Urine in the bladder is sterile. Urine in the bladder is sterile under normal circumstances.
Okay.
Usually an infection comes from the outside inward. So it migrates up the urethra to the bladder. Okay?
So UTI is from the outside?
From the outside.
From the outside. Sorry.
From the outside. And I want you to think about this. You guys probably do this all the time. You don't even think about it. You just do it. You wipe before you go, or you wipe after you go, or whatever, you wipe. You have a certain amount of hygiene. I'll just say it that way. I'm not being, I'm trying to be very, nice about the way I say it. But you have a certain amount of hygiene. That hygiene is important to actually maintain things. And like I said, unfortunately, females, because their urethra is shorter than males, females have a higher incidence of UTIs because of that shortness. It's just, it's just anatomically different that way. Okay, so that's why it happens. Let's take a look at a bladder, another bladder. One of the things you'll notice, and this is a nice example where you can see it. This is actually a mid-sagittal slice of a cadaver. This is a female. You will actually notice that the pubic symphysis is to the far right. You guys see it? You see it back there? Okay. So you have the pubic symphysis right here. Here is the urinary bladder with the urethra. This is a female, like I said. And posterior to that and above it is the uterus. There's the uterus right there.
I'm sorry, can you point out the synthesis again? Oh wait, there it is. I can't see that. I can't read that on the glasses. Oh, okay. Yeah.
And posterior to that, the rectum. So, like I said, this is a female. When you're looking at the pelvic cavity and seeing how it's positioned, you can then see why it's so close together and that there is more pressure on the bladder due to the other structures. Okay? Males are not quite as compressed due to, there's no uterus there. Okay?
There's none.
If there wasn't, because anatomically they're different, that's all. So, and I do want you to realize that when we see it, that's just how it is, okay? The bladder can contain 700 to 800 milliliters of fluid. It does have 3 layers of muscle. And like I said, we actually look at the mituration, urination, and voiding as basically they stretch, and then what happens is you then have the message. Basically 200 to 400 milliliters is when you actually get enough to actually get the message. But you can hold more than that. 200 to 400 is typically when you get the message, but you can actually get 700, 800 milliliters.
That's to a point where they're just painful.
Oh yeah.
That's when you risk.
Like, when you're like,
Yeah.
you have to go, but you can't go, it's just like, your bladder is about to explode.
Like I said, if you're in middle New York and you actually have to go and you can't find any place, guess what? You're gonna hold it until you do find a place.
Yeah.
And you may actually get it where it's,
Sharp pain.
yeah,
Yeah.
yeah.
So worse is when you're sitting in the car too.
Oh,
That is the worst.
yeah.
If you're in traffic, and then every car movement, yes.
Mhm.
And like, especially when you're like close to your location, like.
Whoa, we gotta go. Okay. So, let's go. I'll talk to you.
Wait, so
Talk to Gina.
We'll go, that's it.
I thought this was Wednesday.
I'll say it on Tuesday, how's that?
We're doing the test Wednesday now because we have one more lab, right? And we have to go over pH and acid.
Yeah, we do.
Okay, so
That's why.
test is Wednesday.
We'll see, okay? We'll see.
Well, we can't have a Tuesday, is what I'm saying.
No, it's not Tuesday.
Okay,
Oh,
so it'll be
oh my
Wednesday or
goodness.
late, okay.
Okay?
For the